Good morning, everyone, and thank you for joining us today. My name is Sharon Merriman Nye. I'm here at the Center for Drug and Health Studies at the University of Delaware, and we host the State Epidemiological Outcomes Workgroup. Today, we're having a webinar that's going to be a data discussion about one of our bigger data products that comes out. In fact, it's the biggest data product that we produce. It's the annual epidemiological profile for the state of Delaware. And what we'd like to do is ask you, as you join today, to sign in, let us know where you're from. And it would be helpful too to know if you've already used the Epi Report, if you've ever seen it, how you might have used it, or if you're new to this entire SEOW data resource. We'll get started in a minute. It's great to see you all here. I can tell from the list of folks in the room that many of you already have, in fact, used the Epi. So it's a few minutes past 11. We're going to go ahead and get started. As I said, my name is Sharon Merriman Nye. I think I know most of you folks that are in the room today. I'm here today with Rachel Riding, who is one of our doctors and researchers here at the University Center for Drug and Health Studies, who works on the SEOW project along with me. We have a whole team of folks that work on the project here. And we are doing the, we are convening the SEOW. If you'll go to the next slide, Rachel. We convene this on behalf of the Delaware Department of Health for Health and Social Services, Division of Substance Abuse and Mental Health, with funding from SAMHSA. Originally, the SEOWs were created as part of the Strategic Prevention Framework Initiative that was a federally funded project. In recent years, DCM has continued to fund this initiative because of their commitment to data-driven programming and evaluation. So we thank them for their support on that. And we have our link, and I believe that in the chat this morning, Stephanie Ha, who is also working with us at the center, is going to be populating a number of links to various resources that you might find of interest. We have an explanation of what the SEOW is, and we talk a little more in depth. And of course, we have the Epi Report online. We have slides that go along with that and some other materials, as well as other data products that we'd like you to check out. Today, I'd just like to emphasize that what we're doing today is not going through and giving you every data point that you would possibly be interested in learning about that is included in the Epi Report. As I said, it's a very comprehensive profile. It contains information from over 50 data sources. We have over 200 figures and graphs in the report that address substance use, both trends and rates of substance use. We talk about risk factors and protective factors. We talk about mental health and wellness. And we also take a look at cross-cutting issues like trauma, adverse childhood experiences, and protective factors as well. We look at populations that experience disparities in these areas of behavioral health as well in the report. So what we're doing today is just giving you a very high-level overview of what this is. We're going to touch on some of the very some of the key takeaways from each of the chapters in the report. And we're going to then just turn it over to you for some questions as you go through. So what I'm going to do is just talk a little bit about the SEOW. If Rachel, if you would just go back to the slide before. Right, so there are 4 goals of the SEOW, and that is to identify, analyze, and share data. We also create data products, including the Epi Report. We are here to help train communities in understanding and using the data, because as we know, data in and of itself is meaningless if it's not put to use in applicable ways. And then through these efforts, we build a state and local level to monitor behavioral health indicators in the state. If you'll go to the next slide. So a number of you in the chat have already said that you're using the Epi report, you've seen it, and it's something that you have acquainted yourself with in the past. We have produced this report for approximately, I think, 14 years. It's grown both in the topic areas that it covers, and it also is more, we've included narrative around it to try to put some context around some of these issues. But the report itself is a good resource for many things that you're doing in terms of your programming, whether it's assessing needs in the community, whether it's applying for funding through grants, if you're establishing an evaluation strategy, if you are looking to educate and raise awareness or interface with the media as well as community groups. These are the kinds of things you can draw on the report for. I will also say that the report it captures what we can capture about these data, but you may have follow-up questions and you may want to reach out to our team for additional assistance in terms of looking for specific data points that maybe are not already in the report. So we encourage you to remember that the Epi is what we put out there for everyone to do self-service with, but we are also here to back up that with any kind of customized requests that you might have for assistance. We do the best that we can in terms of directing you to these sources or helping you wherever the data is. Sometimes there are limitations as to the data, but we do our best to try to fulfill whatever questions you may have to support these behavioral health prevention and treatment efforts in the state. Next slide. So I mentioned that we draw on a number of resources for composing, if you will, the report. On the left-hand side of the screen are all of the standard data instruments that we report out on. And then on the right, we include additional resources that we look to sort of flesh out the picture of behavioral health in Delaware. Next slide. So in addition to the report itself, we create a number of products that support its use and perhaps are more, they're more valuable in different settings. So we draw up an infographic for each of the chapters in the report, and we produce those annually. These can be downloaded and printed if you want to share them in print form, or you can share them electronically with your various constituent groups. And as I said, these again are just the highlights, but it's something to hand out. It's something to focus discussion on for a variety of topics that you may be working on. Next slide. In addition, we had a request from several of our folks who tend to use the Epi report pretty substantially and do a lot of presenting to create slides out of these figures and charts. So we've taken the report for the past several years and we've created a slide deck that you can download or incorporate into your presentations or other materials. It's all on our website. And I think, Stephanie, did you want to just, every now and then, you can just pop that landing page in for the Epi report and its products. So as I said, those are all posted online now. And if you'll go to the next slide. So I just want to talk for a minute about what's new in this particular year's edition. Every year we do try to continue to seek out new sources of information and data. And this year we were able to incorporate mental health data for adults from the state of Delaware, as well as the national data on on mental health indicators of depression and anxiety. These come from the Household Pulse Survey. This was a project that was initiated in response to the federal interest in understanding how behavioral health might be changing in regards to the pandemic, and it has continued for the past several years. So we have that data in there, which is new. We also include in the Epi report various policy updates and items that are narrative items that are of interest. So we included this year a number of policy and state and local level legislations regarding behavioral health. There were a number of things in the state of Delaware, you know, that were passed legislatively about mental health services in Delaware. So we've included information on that and other topics. And the other thing that we've done is in recent years, we incorporated a chapter on adverse childhood experiences into the report, but we wanted to expand on that to take a broader look at trauma. Although ACEs are traumatic, there are other forms of trauma, and we wanted to take a look at that as it impacts the life, you know, people throughout the lifespan. So we have broadened the lens in that chapter. And at this time, if you'll go to the next slide, Rachel, I'm going to turn it over to Dr. Rachel Riding, who is the data editor of the report. And she is going to walk through the report, talk a little bit about, you know, some of the notes on the data, and then actually go through and share some highlights from each of the chapters. So Dana, Rachel, I'm sorry, I was thinking of Dana for a minute, who is another one of our researchers. Go ahead and take it away.
Great, thank you, Sharon. So I'll be talking a little bit today about these highlights that are within the Epi report, as Sharon has mentioned. And first to start, I'm gonna go over some of our data notes that we have. So we have some guidelines that we follow when reporting in the Epi, when using our own data sources. And so this will be familiar to most of you. These have been in the Epi report for the last couple of years now, and they're also posted on our website. But I just want to give a quick run through of these before we get into the data, because it's a good place to start. First is our reporting for small numbers and our rounding. So we have a threshold that we use for reporting statistics. And typically when we're looking at our school survey data, if we have responses with fewer than 30 students, we won't report a bunch of affiliated statistics with that data because it becomes difficult to report things reliably once you get to really small numbers. And also we round all figures to the nearest whole percent, just as a practice with our own data. In terms of missing observations, with any survey data, you're going to see certain questions where you have different prevalences of missing data. This can be for a variety of reasons. With school surveys, it's often either the surveys can be kind of long. So by the end of the survey, there might be students who are no longer focused on the survey or who ran out of time. So sometimes the questions towards the end of the survey might have different rates of missing data. And there are also some questions that students may decide to skip or not respond to for various reasons. Like if they're scared that their answers might not truly be anonymous, students may not respond to certain questions related to substance use or other behaviors if they're afraid of getting in trouble or something like that. So there's always some level of missing data, and we typically just don't calculate missing observations into our percentages. And this does mean that sometimes the total sample size for different questions may vary slightly depending on the number of missing cases with each question. We also use the threshold of P's less than 0.05 for statistical significance. I've said that a million times and it always trips you up. It's a tongue twister. Statistical significance. If that's a metric that you're concerned with, you know, when we report school survey data, everything we report, unless otherwise noted on the figures, is statistically significant at this P less than 0.05 level. You know, there may, because we have practices for handling our own data, there may be discrepancies in what we report versus what other data sources might report. You know, different researchers, different data sources, different agencies may handle things like missing data or rounding a little bit differently. They may use a different threshold for significance. So these are all things just to keep in mind if you're looking at our data and then you see something similar somewhere else. If it's slightly different, a lot of times that might be why. And then some of the data we report is also weighted. Any of the data in the report that is weighted, we note in the footnotes whether or not it's weighted data. So YRBS data when reported is always weighted. Delaware School Survey is not typically weighted. And we have these notes throughout the report if something is weighted to be more representative. And I think the most important thing that is a little bit new to this report, we're constantly grappling with what impact the pandemic has had on data collection and the analysis of that data. And obviously with school survey data, there are challenges with physically getting into schools and doing surveys when schools changed a lot of how they were doing things to accommodate the needs of the pandemic. So in 2021, the Delaware School Survey was administered entirely online, whereas historically it was a paper and pencil survey with administrators physically going into schools. So because of this, we might see some differences in the data that was collected based on maybe students who are responding or students who may have responded differently because it's in an online context and not them all sitting at the same time in a classroom doing the survey together. And it'll be a few years of data cycles for us to really see what some of the impacts of changing this format may or may not be, but something to keep in mind as we're going through this presentation. And I'll talk about this a little bit more too on some specific figures where we've seen maybe drops in use that we weren't expecting that we need to consider. Is this truly a change in the trend or is this a pandemic anomaly? And finally, we like to give just a glimpse at the total ends for the school surveys that we're reporting, just so you can get a sense of the numbers behind a lot of these statistics. So in 2021, we had 2,601 students respond to the 5th grade Delaware School Survey. We had 2,896 students respond to the 8th grade survey, and we had 1,597 students respond to the 11th grade survey. So we do have new Delaware School Survey data for all 3 grades in this 2022 Epi report this year, which is great. Because last year we only had the 8th grade data. So we're able to fill some of those gaps again this year, which we're really excited about. We still don't have new YRBS data in this report. 2021 has been collected and that data has started to come out, I believe, but we don't have it in this report. We're hopeful that in 2022 we'll have some data to report on that's come from the CDC on 2021 in Delaware. So in the Epi report, the most recent YRBS data that we have is the 2019 middle school data. In 2019 high school, there was not enough respondents to the YRBS to get weighted data, so that wasn't reported. So just to give you a heads up, if you're looking for some new data there, we don't have it yet in this report, but we're hopeful that by next year we will. And now that we've gotten some of the data notes out of the way, I know that's a lot, but it is important just to kind of touch on those things before really getting into the data. I'm going to give an overview of some of the key findings from each of the chapters in the report that we have new data for this year. If you have questions as we're going through, feel free to pop them in the chat. If I don't get to them during the presentation, I certainly will by the end of the presentation. And as Sharon mentioned, we have 13 chapters in the Epi report. The first segment of chapters predominantly focuses on these core categories of substance use, so tobacco and electronic cigarettes, alcohol, marijuana, opioids, and other illegal drugs. And we also have kind of an overview chapter at the very beginning where we have give state overviews of substance use, and we have our heat maps and things like that. And then the last half of the report is where we have our special topics chapters. So it's infants with prenatal substance exposure, gambling, mental health and wellness, disabilities, adverse childhood experiences and other trauma, gender and sexuality, and protective factors. And there are 2 chapters this year that we did not have new data to be able to update substantially, and that was the infants with prenatal substance exposure and the gambling chapter. Again, we're hopeful that in 2023, we'll have some updated data to incorporate into those chapters. So I won't be discussing chapters 7 and 8 today when I'm giving some of these highlights. Just to give you all a heads up, if anyone's wondering, why didn't she talk about that? We're hopeful that next year we'll definitely have some data you know, we're all still navigating this landscape where there are some gaps in data sources being available, or the timing of collection and processing of data. But so to begin with, you know, I just want to talk about the snapshot of substance use that we have in the first chapter, where we look at past year substance use among 8th grade students. And on the next slide, I have 11th grade students. And among 8th grade students, alcohol is the most prevalent substance, which is no surprise. Alcohol tends to be the most prevalent substance across age groups. So we have 13% of 8th grade students who report using alcohol in the last year. And then 7% of students are reporting marijuana use, prescription misuse, or vaping. So marijuana, prescriptions, and vaping are kind of in this three-way tie for the second most prevalent substance used by 8th grade students in the past year. And when we look at 8th grade students, there's a little bit more of a clear ranking in terms of what's the most prevalent. So about 31% of students, or a little less than a third of 11th grade students here are reporting past year alcohol use. About 21%, so close to 1 in 5 students are reporting that they've used marijuana in the last year. About 14% are reporting that they vaped in the last year, followed by prescription misuse, and then other illegal drugs. And then cigarettes among 11th grade students has gotten so low that we don't have a statistic to report with it. It's less than 30 students have responded that they use cigarettes in the past year. And, you know, piggybacking off of that, those declining rates of cigarette use that we're seeing, we also saw in our trend charts this year that the perception of risk associated with cigarettes went down, which is interesting because it's something that perception of risk, of great risk associated with cigarettes, is pretty much a universally known thing at this point. And the perception of risk has remained consistently high for a long time among young people. That, you know, they know smoking cigarettes is bad. And then in 2020 and 2021, this perception of risk has kind of dropped back down a little bit. And that's one of those things where, again, we don't know if that's an anomaly related to trends during the pandemic with how the data collected, or with the students who are responding to the survey, or if that's really a new downward trend. And it's something that we'll need to track for the next few survey cycles to see if that stays low, or if that perception of risk kind of pops back up again, which we would expect it to remain high. I don't think cigarettes are suddenly becoming more popular again. And even with that, that dip and that change of perception of risk, the rates of self-reported use of cigarettes have still continued to decline and decline and decline. And you'll see we've got some, a few holes here at the end. Some of that is because the self-reported use of cigarettes in the past month is so low. It's below 1% of students, below that threshold of 30 students. In 2020, that was because the data wasn't available. And in 2021, we do have data again, but it was so few students reporting that they used cigarettes in the past month. So cigarette use is continuing to decline. And then with vaping, again, you know, we started measuring this in 2014, asking students if they've used electronic cigarettes. As the years have gone on, we've expanded those questions to ask about other vaping devices, to ask about Juuls, to try and expand upon the different devices that are out there and the different terminology that young people are using to talk about it. And vaping reported among 11th graders kind of peaked in 2019 with our data. We didn't have data in 2020, and now in 2021, it's dropped back down again. And this is another thing where you know, we'll have to keep watching the data and see if, you know, if in a few survey cycles, is vaping going to go back up again, or have we really seen the peak of this trend? And we do have one comment in the chat box I just want to address about combining cigarettes and vaping, and the question about risk. And this is actually, I'm sorry if the title of this was misleading. So the entire chapter is focused on tobacco and electronic cigarettes, but this question about risk is specifically just about the perception of risk associated with cigarettes. So we don't combine tobacco and electronic cigarettes into one indicator when we're asking students about if they feel behavior is risky. This question asks just specifically about cigarettes. The headings here refer to the title for the entire chapter in the Epi Report. So in the Epi Report, we have cigarettes and more traditional combustible tobacco products and vaping in the same chapter, but in these figures, we do differentiate between cigarette use and vaping use. So I apologize for any confusion there. All right, and then just to highlight a couple of figures from the alcohol chapter, yeah, we see, again, that similar to other substances, there's this decline in these last couple of pandemic years and what's been reported. And so while binge drinking has been slowly but steadily declining, it kind of cut in half from 2019 to 2021 among 11th grade students in particular. And again, we'll have to see as we're continuing to collect data and monitoring trends, is this a change that is going to be sustained over time? Is this a change that was specific to the pandemic in terms of changed opportunities for use, or in differences in who was responding to the survey because it was entirely online rather than students all together in a classroom doing the survey on paper? And we also have some adult alcohol data, which I always think is interesting to highlight. This is from the 2020 Burfus survey. So we see that the highest rates of current drinking are among 35 to 44-year-olds. That's 57.4% of 35 to 44-year-olds are current drinkers. This is people who have reported drinking alcohol in the past month. And even though the most current drinkers are in this age group, the higher risk drinkers are in the 18 to 24-year-old age group. So even though more people report drinking in their 30s and 40s, more people in the ages of 18 to 24 are reporting binge drinking or heavy drinking, which is the higher risk drinking behavior. All right, and we have another comment in the chat book that 2022 has had the highest number of calls to poison control centers in the US for vaping use. So thank you for sharing that. So even if we're seeing in our data some declines in reported vaping overall, other data sources are seeing increases in calls for poisoning events related to vaping. And again, with trends in past month marijuana use, similar to alcohol and to vaping that we've seen in our data, there's a big drop in from what students reported in 2019 to what students reported in 2021. And I just want to emphasize, similar to what we've been talking, I've been kind of sharing the same thing with each of these substances to get that point across, that we're seeing much different things in our data in 2021 and things that we didn't necessarily expect, and that this is data that does need to be interpreted with caution because there are so many other just moving targets that are going on during this time of the pandemic that are changing social behavior, that are changing how we're measuring this behavior, and all these things could be impacting some of this data. So it could be premature to say, oh, well, vaping has gone down, or oh, marijuana use has gone down, because we truly don't know all of the different competing reasons why that might be changing in our data. But these are shocking decreases to see if you were just to look at these charts out of context without keeping all of those things in mind. We do continue to include data from the Delaware Prescription Monitoring Program in our chapters on opioids. in the Epi report. And well, in 2021, there wasn't data available for treatment-related opiate prescriptions. The other types of opiate prescriptions that are tracked by the PMP, which is those high-dose opiate prescriptions, extended release and instant release, those rates of prescriptions have continued to decline. And we are still seeing, based on the data for 2021, from the Division of Forensic Science, that fentanyl was involved in the vast majority of opiate overdoses. It's 425 out of 515 that they tracked in their report for the year of 2021 involved fentanyl. And we're definitely still hearing reports of lots of different things going on in the illicit drug supply when it comes to overdoses and emerging trends that will need to continue to be tracked as data is coming in. And as Sharon mentioned, we've included data on the household pulse survey that's come from the CDC. So this is a survey that's done every 2 weeks. So it really is capturing that pulse every 2 weeks of what people are reporting in terms of symptoms of anxiety and symptoms of depression. It's a pretty cool tool. There's not, a lot of the other data sources that we report on, the data is often pretty far behind from when it's collected because it's such a large scale. Like if you're thinking about the National Survey on Drug Use and Health or some of these school surveys, it's kind of that like one point in time, and then we get the data much later. And the pulse data is cool because it really is that pulse every couple of weeks, and it's pretty recent data. So what we have in the report goes from June 2021 to July 2022. So some of this data is just from earlier this year, which is great to have data that recent. So we have two figures in here. One is trends in symptoms of anxiety disorder, and one is trend in symptoms of depressive disorder. So you'll see this green line here is the national prevalence of folks with symptoms of an anxiety disorder. And they're asked a series of questions, and then those questions are scored. And if you're scored above a certain point, that's how they're marking having symptoms of an anxiety disorder. And I can share those more specific notes if folks are interested in the actual questions they're using. But we see that the Delaware line, at a few points, it kind of dips above the national average, and then kind of dips below at a few points, but it's ranging from 22 to 30% of Delaware adults that are reporting at any given time that they're feeling these symptoms of an anxiety disorder. And then similarly, we see with the symptoms of depressive disorder reported by Delaware adults, there's slightly lower overall rates than anxiety, but we're still seeing, there's a few points where it's dipping above the national average, and then points where it's kind of dipping below, but there's these peaks and valleys. And so among Delaware adults, between 15% and I think 26% is the highest, have a rate of reporting symptoms of depressive disorder as captured by the household pulse survey. Thank you, Sharon. Sharon popped some of those questions in the chat box if anybody is interested in seeing those. We keeping in this theme of mental health and wellness, we're continuing to look too at experiences of anxiety and feelings of anxiety and depression among some of these other populations of students that we're capturing. And we see pretty big disparities in students reporting feeling anxious or feeling depressed when they have one or more disability compared to students who don't have any disabilities. Excuse me. So in 2021, among 11th graders, 47% of students with one or more disability reported being anxious on more than half of the days in the past 2 weeks. Compared to about 18% of students without disabilities. And there's just as severe of a difference when we're looking at depression as well. 44% of students with one or more disabilities is reporting symptoms of depression compared to about 13% of students without disabilities. So it's 2 or 3 times the difference. Excuse me, as Sharon mentioned, we included a few new things in the ACEs chapter this year. And one of those things has been, there have been some questions added to the Delaware School Survey pertaining to feelings of safety at school and experiences of gun violence. So you'll see in this bar here, we have each of the indicators that we include in our ACEs variable. And then on the left here is kind of our pie chart of students who've that accumulation of ACEs, so 0 or 1 or 2 or more, or 3 or more, or 2 or 3 or more. And you know, we've added this question about gun violence. And I think it's pretty stark that 23% of the 11th graders we survey report that they've either been a victim of gun violence or they've known someone who was a victim of gun violence in their lifetime. So we are, in our analyses, we're considering that is an experience of a form of trauma. And then we've also looked at this question where we asked students what they feel would make their school safer. And the majority of students are responding that providing mental health counselors or school psychologists would be one solution for making their schools feel safer, which is really interesting that students are identifying that, that the majority of students are identifying that they have a need for more mental health supports through their schools to help them feel safer. Just a few more to go here, and then we'll open up for some questions and some more discussion. So in 2021, we do have a question asking students about their sexual orientation. We did not have a question in the 2021 survey asking about gender identity. In 2022, we should be able to analyze gender a little bit more when we're talking about gender and sexuality. But for right now, we just have an LGBTQ variable in the 2021 data that's included in this report. And even now we see that, you know, close to a quarter of 11th grade students are identifying their sexual orientation as something other than heterosexual. We got 3% saying that they're gay or lesbian, 13% reporting they're bisexual, 3% reporting a different sexual orientation, and then 4% that they're not sure, that they're still questioning, which is a pretty substantial proportion of the student population. And what we see among those students that are identifying as LGBTQ based on their sexual orientation, that there's also real differences in self-reported emotional health. So if you look at these bars, the orange is the heterosexual students and blue is the LGBTQ students. So when we ask students, how would you rate your emotional health? Only 3% of LGBTQ students say their emotional health is excellent, compared to 19% of heterosexual students who say their emotional health is excellent. So that's, you know, 6 times the students. And then when we look at fair or poor reports of emotional health, you know, more than a third of LGBTQ students say their emotional health is fair. More than a third of students say their emotional health is poor, compared to 22% of heterosexual students or 9% of heterosexual students. So there's these real extreme differences at either end of the spectrum in terms of which students are rating themselves as having pretty good emotional health and which students are rating themselves as having pretty poor emotional health. And then finally, just a couple points about protective factors. This is our last chapter in the report. We do ask students about you know, who are their sources of support and encouragement. We know that for young people, having support and encouragement from the adults in their life can be very protective against a whole number of adverse outcomes. So about 81% of 5th grade students say that their parents are a strong source of support and encouragement, followed by their friends, their siblings. The majority of students also find support from their teachers, from their grandparents. But we still have, you know, 5% or about 1 out of 20 students saying that they have nobody who provides them with support and encouragement in their life. And we also know that things like feeling safe where you live can be very protective for a young person's mental health. So it's one of the things we highlighted in this particular graph is that students who feel that they, who feel safe in their neighborhood, most of the time or often are reporting lower rates of feeling anxious and feeling depressed than students who don't often or ever feel safe in their neighborhood. So students who most of the time feel safe in their neighborhood, only about 24% of them are feeling anxious, whereas half of the students who don't feel safe in their neighborhood are feeling anxious most of the time. So it's a pretty stark difference in emotional and mental state for students who don't feel safe. And finally, to end on another positive note, we've got some updated data from the National Survey of Children's Health. And they have a family resilience composite measure where they add together a few different items that families can report on how often they engage in these things in their homes. It's talking together about what to do, working together to solve problems, knowing we have strengths to draw upon, and staying hopeful even in difficult times. All these individual things are qualities of resilience. And in Delaware, so the red bars are Delaware and the blue bars are the national estimates. And in Delaware, 78.9% of the families surveyed, either all or most of the time are reporting that all four of these qualities of resilience. So the majority of families surveyed are reporting the majority of these measures of resilience in this survey. And that's it for our quick run through of some of the data highlights. So thank you so much for listening, and we'll open it up for some questions now. I'm going to start scrolling through the chat and see what we missed. So if you have a question and want to pop it in the chat, or unmute yourself to ask the question, and Sharon or I or one of our team members will be happy to answer whatever we can. Thank you.
Bill, I just wanted to I wanted to just answer your question about whether
Sharon, if you don't, I'm sorry, it's MJ. Hi, good morning. I was slow to unmute. If you don't mind, I'm going to take that question if that's okay.
Great, thank you.
Great. So, hello, good morning, everyone. It is obviously, xylazine is obviously an emerging trend and an emerging issue here in the state of Delaware. And it is something that we are keeping a watchful eye on from a data perspective. But we are working with our state partners to push out that information in a way that is accurate and factual, and not adding to misinformation and or panic. So we are working on our end to make sure that we are communicating and getting that kind of information, which has recently started being tested for in overdose scenarios. And I see Katie Capelli has raised her hand, which is a great, one of our DPH partners. But from a SEOW perspective, we're going to wait for that data to be accurate to inform those types of conversations so that we're not contributing to misinformation or panic.
Katie, do you want to chime in, please?
Sure, yeah. Hi, Dr. Lynch, how are you again? So again, I'm with the Division of Public Health, and we actually help to fund Division of Forensic Science for all their postmortem cases, toxicology cases. And xylazine is definitely something that we are putting in a request to have it accredited for. Right now, we currently don't have the capability to test, but hopefully early next year, we have the funding, and hopefully by early next year, we'll have the training and the accreditation to test for xylazine. And I would second what MJ said. We know that it's a prevalent issue in surrounding states and also in Philadelphia and Baltimore in particular. And it's definitely something that the Division of Public Health intends to fund and intends to look into to collect that data. So we'll have that available hopefully in the near future.
Thank you so much for providing that additional context.
I went ahead and I popped into the chat the link for the Division of Forensic Science 2021 annual report if anybody wants to take a look at that. Do we have any other questions? I know there was a lot of information shared today. And as we can't emphasize enough that this is just a very high level overview of the report and the information included in the report. So you may want to take some time to do a deeper dive into it yourself. We hope that you do. We hope that you can take some time and actually pull the report up and look at it, because in addition to the data points, we do provide a fair amount of context around the issues, including, you know, a look at the national view on these topics, and then after that, a Delaware focus on these topics. Rachel, is there anything that, or to the group in general, I would just like to ask, is there anything that popped out about the data that we talked about today that just seems noteworthy or surprising perhaps?
Sharon, it's Bill Lynch. I just think what's one of the ones surprising is that with your data being 2021, I think you're seeing a natural COVID dip, which has been shown in the other ones. And like Rachel said, there's definitely a lot of different factors. One of those for sure is in 2022, we've definitely seen an uptick. There's no doubt about that with some of the national data. The xylazine, the reason I brought that issue up is because I can tell you from the perspective of the Commonwealth of Pennsylvania, it's been in every county in Pennsylvania, and it's 39% of all the samples now have xylazine in it. And in New Jersey, it's been in every county. They're all 21 counties in New Jersey, and they have seen 35% of their samples tainted with xylazine. The reason it's a concern, I'm sure Katie can elaborate on this as well, as the first wave that we had that hit us was we now have naloxone-resistant opiate overdoses, and we actually don't. Naloxone will not reverse xylazine, so that is the issue. The toxidromes are similar, so they look like an opiate overdose, even if they just have a xylazine overdose. But the issue is that you should still give naloxone all the time. It will reverse the opiate component, but it will not affect the xylazine component. So that's one of the big factors with regards to that. And the vaping has definitely taken off. One of the things that that I think Rachel will find interesting is with regards to the alcohol consumption. Rachel, there's information that came out now showing that during the pandemic, the alcohol deaths went from about 6,000 to 10,000. But in particular, the question was, which you actually showed the data, which I'm going to get that slide. You know how much I'm a slide guru from you guys, and I appreciate all those. But the one you showed where the younger people had the higher problematic drinking is very interesting because it correlates to the national data, because the national data showed of the increases of deaths, who had the highest amount. 35 to 44 was highest, followed by 25 to 34, followed by 16 to 20. They had almost a 30% increase in alcohol-related deaths, even though they can't purchase alcohol, supposedly. So what's interesting is where you showed that the younger 18 to 24 had the problematic drinking issues, they were actually 16 to 20, and then 21 to 24 had the third and fourth highest increase in alcohol-related deaths during the pandemic. So that does correlate to the data that you showed today. So thank you for sharing that, because that data that I have in that slide will now be coupled with the data you just loaded in your slide today. So I appreciate that.
Yeah, thank you. And we'll definitely make sure that you get these slides.
Oh, as Sharon knows, we brought this up and you guys have been great with that, and it just makes us not have to make them, which is tremendous to be able to share the information. So we truly appreciate those. I do have a question is, I assume that you guys will still be having your heat maps. Either Rachel or Sharon can answer that with regards to this date.
Yes, we do have, and the newest heat maps are in this version of the Epi report, which is online now. I don't know if we have the heat maps posted separately yet at this time, but we do have new heat maps that are in that first chapter of the Epi report that is online.
Well, my student who's on here, Gopal, is actually, if you don't have them in slides, Gopal will find out for me today that we will probably by the end of the week, because we'll be using it. I will tell you that data is very impactful when you present in our state, because as small as the state is, when you're able to show what your heat maps are tremendous with this, the zip codes where either schools are located or where people live, that has a major impact on them realizing that this truly is in their neighborhoods, because it's down to the zip code level, which is really important for our state. So thanks for sharing those, and also to being that specific by zip code.
Bill, I'm popping the link in the chat right now for the slide deck, and they are in there.
Terrific, thank you.
Great. Yes, I do. I want to give you a thank you for the recommendation that we make the slides available to folks, because we do know that they help in creating presentations. And MJ just popped in the chat that they will be updated in January on the website. I'm assuming that's what you meant. Okay. Cheryl asked if the household pulse survey data can be disaggregated by any demographic variables like sex. Actually, Cheryl, I would have to go into the portal online and take a look at that. We did not do it, but that's an interesting question. It always comes, you know, it always is interesting to me how much we can slice and dice the Delaware level data, because of course, this is a national survey and they're able to do it by state, but I would have to take a look at that to see if we could parse that out. Good question though.
Yeah, and I did just pop in the link for the current data table for the household pulse survey from the CDC. So this is just a link to the national, but you can play around in this a little bit to get state estimates. But they do have things broken down by age group, by sex and gender, by sexual orientation, race and ethnicity, education, disability status, and then by state. So they do have a few different breakdowns there that you can look at in their tables. It's a pretty neat data source. And the most recent that they have in there now, the last date was November 2nd to November 14th that is up online. So that's, you know, barely a month ago. There's some data there, which is pretty cool.
And I want to give a shout out to Dana Holtz, who first introduced us, and Rachel, I think it was about a year ago when you all presented information for the first time on the household pulse survey, because it is a wonderful resource. Thank you.
Do you have intentions of following the changes in marijuana use in young adults and also in the youth in the schools, especially with New Jersey having recreational marijuana introduced in April of this year, and the state of Maryland has just approved it recreational use in their last election cycle? I don't know what the actual launch date is for that to actually occur in Maryland, but I'm very interested to see if that will actually cause a shift in consumption, especially downstate into the western part of the state that borders Maryland, compared to what may have happened in Newcastle County, especially northern Newcastle County, with New Jersey having recreationalized it back in April of this year. It'd be an interesting trend to follow when you guys look at the data moving forward.
So are you suggesting this would then go to the heat maps that you're talking about, Bill? Well,
the heat maps, and also I think it'd be interesting. I know when they released the Rocky Mountain HIDA report, they actually show based on when Colorado actually had medical marijuana, and then when they actually legalized it recreationally, they show you the spikes that they've had, even in other consumption of other substances, that since it's been legalized. As example, methamphetamine and heroin treatment emissions went up significantly in Colorado since marijuana became readily available. What'll be interesting is that even when you do your maps, when you use a trajectory showing chronologically left to right, if you even put an arrow in there that says this is when it was April 20th of 2022, New Jersey had legalized recreational marijuana and launched it. It'd be very interesting to see if you would then add an arrow that when Maryland launches it there, do we see an uptick in those heat maps and or the trajectory moving left to right with consumption as well by youth and young adults, because it now becomes more readily available, even though not in our state, and obviously bordering the states may have a significant impact.
Well, that's an interesting point, and we will of course continue. I mean, I am speaking for our survey team, but I can't imagine that there will come a day where we're not looking at the major substance use issues. So we're going to continue to track trends in marijuana, as well as alcohol, opioids, tobacco, and electronic vaping devices. and other illegal drugs as they come out. Those are the biggies that we definitely look at. So I'm sure we're going to continue to collect that data, and how we, report it out will evolve as our technology and capabilities do. So, but that's an interesting thought.
And I do have a question on your ACE data too, because before you had stopped at 2, and now this one looks like you've gone as far as 3. And what's interesting is that the 3 or more showed almost the same incidence as those who had none with regards to occurrences. But what I'm wondering is that, do your numbers just get too small when you go to 4, 5, 6, and 7, or can you actually break that out even to where they get higher sequentially, where there's now 4 ACEs versus 5 versus 6, or when do you finally have a drop off in the numbers that it would be meaningless with regards to your data?
Yeah, so part of that changed, because you're right, we did used to, our ACEs category used to be 0, 1, and 2 or more, and we changed our data source for that. So previously we were using YRBS data to calculate the ACEs, and now we're using the Delaware School Survey, which has a few different questions from what the YRBS had, and also there's just more indicators. So while before we weren't really able to break it down much more past 2 because the numbers got kind of small, and this one we were able to do 3 or more. And again, it becomes one of those things when you start breaking it down to 4 or more or 5 or more, some of those other categories start getting to kind of small, and then we just get so much variation within those that it doesn't become as statistically meaningful to keep breaking it out into those higher and higher numbers. But we do see, across all of the different correlates that we looked at with ACEs in terms of mental health or substance use and some of those other indicators of adverse behavioral health outcomes, that there is a clear progression in negative outcomes and an increase in accumulation of negative outcomes for students who have 0 ACEs versus 1 versus 2 versus 3.
There had been national data that we saw a while ago that actually showed, I think it was if it was 5 or 6 or more ACEs, it was something like 76% of those people engaged in injection drug use. It's significant with regards to trajectory as you start adding them on, becoming 4, 5, and 6, how they increase significantly. So, and Rachel, see, now I was looking at those slides. I knew it stopped at 2 before, and now I know it went up to 3.
Yeah, you're paying attention.
Yes, I am. So thank you for that.
Okay, I'm going to flip to the next slide since we're right about at, we're 1 minute to noon. I want to be respectful of everybody's time. We have our contact. If you don't have Sharon or I's contact information, here are our emails. If you have any further questions or follow up about the Epi report, if you're having trouble finding any of these resources on the website, feel free to reach out to us if you have additional questions about things that we didn't answer today that you'd like to talk about. We'd love to hear from you. Stephanie just popped in the chat the link to the evaluation form. If you're getting CEUs from attending this today, you'll need to complete that link. I'm going to turn it back over to Sharon for any closing thoughts. Thank you so much.
Actually, the evaluation link is actually for everyone. We would like to get feedback on this so that we can continue to improve how we provide information to you all, and if we're meeting your data needs. For anyone who has already taken the pre-test for the continuing education credit, you will get an email with a link to a post-test that you will need to take in order to be able to apply for that credit. So I just wanted to make that distinction. That, again, that will be sent out to you. And we are at time. We had a nice, we had a nice, enjoyable discussion about this data today. At least I appreciate it. Every time I look at it, I see new information that piques questions in my mind. We appreciate the interest you all show in the data, and we are here to back that up, as I said, with technical assistance as needed. So thank you for attending today. We look forward to our next 3D, which will take place sometime in the spring. And we welcome you to share with us any of your topic areas of interest so that we can see if we can provide more information on things that are meaningful to you all. Have a wonderful day. Have a wonderful and safe holiday season, and best of luck to everyone in the new year. We look forward to seeing you in 2023.